Well, this is actually the first of a number of talks that should be approximately quarterly that the MS Foundation is supporting in our region. And we need to start somewhere with these talks, so we thought, why not start with MS 101? This will be a lot of just basic information about what the disease is, and then there's going to be, as I said, about quarterly talks coming up on a number of different topics, and a lot of the topics have not even been selected yet, so if you have a topic you're interested in, just make sure the organizers know that you're interested in hearing about that at some point. But getting into MS 101, I thought maybe we might just talk about the name, sclerosis, which comes from actually a Greek word, which I see that PowerPoint corrected the spelling onto the English word again, but sclerosis in Greek is spelled with an SK. It means hardening or stiffening in Greek. And there's a whole lot of diseases that have the word sclerosis in them. So some of the ones that that you might have heard of is atherosclerosis, which is hardening of the blood vessels, or otosclerosis, which is hardening of the bones in the ear. So it's basically what happens when you get old and get hard of hearing. Or glomerulosclerosis, which is a kidney disease, or lichen sclerosis, which is a skin disease. So there's a whole lot of these things. Most of these diseases were named with sclerosis in the title at a time when we didn't have very sophisticated ability to diagnose diseases, and a lot of it was done on pathology, and they didn't have back then a lot of fancy stains and stuff, so basically you were doing an autopsy and you feel the blood vessels and they're like hard, and you say, wow, this is atherosclerosis. And so that's how MS got its name back in the mid-1860s, when the first person that described it in the medical literature noticed that at pathology there were all these hardened areas in the brain. This is a picture of half of a brain from a person who had MS. And this big hole in the middle is the ventricle, where the spinal fluid is, and it's large because the brain has shrunk a bit. And then you have white matter and gray matter that everybody has in their brain. The gray matter is usually along the surface of the brain. And then the white matter is kind of a little deeper, and it's white because it has myelin, and myelin is mostly made out of fat. So that's why it's white. Along here, right next to this ventricle, you can see these gray patches, and those are MS areas. We call them plaques or lesions. And if you were to feel this in a fresh autopsy specimen, those areas would be harder than the normal brain around it, and that's why they named it sclerosis, and it's multiple. This one has several spots just in this one slice. So that's where the name multiple sclerosis comes from. This is what it looks like under a microscope. And on this particular slide, they have stained it so that the myelin is blue. And this little thing here on the bottom, that's part of the cortex where there's not much myelin, so that's okay. You can see in kind of the left lower side, there's a lot of blue there. And then this whole right upper side, the blue is just missing. And that's because the myelin has been stripped off those nerves in that area. And that's an MS lesion or plaque.
Well, that's red to me.
Red?
Is it my eyes?
It's probably the projector. It's blue on this screen, and I can't see any color from the side. You can see here there's a little round thing in the upper right, and that is a blood vessel. And for reasons we're not entirely, that we don't entirely understand, these MS lesions tend to start around these small veins. This is an example of a lesion that's kind of around, starting around a vein. They can get bigger and then they can coalesce with other ones so that they're no longer right around a vein because there's, it's a bigger lesion, but they tend to start right around the veins. If you increase the magnification on the microscope, you get a picture like this. And on the left side of the screen, you can see it's kind of pinkish. This stain, myelin, is pink on this stain. So this side here has, the left side, more intact myelin. But the right side, there's a lot of pink that's missing. And that's, again, because the myelin has been stripped away. You can see that there's a lot of little dark dots on there. And some of these dark dots are lymphocytes that are in there with inflammation. Lymphocytes are part of the immune system that I'll talk about later. And then there's these, like this one here, scattered around. There are these larger cells that are pink. And those are macrophages, which are the garbage disposal units of the immune system. And they're big and pink because they're stuffed full of myelin breakdown products, and they're trying to pick it up, digest it, and haul it out of the way. So that's what it looks like. And because of these lymphocytes and macrophages that are in there, that's why the immune system is believed to play a key role in this disease. There was a huge breakthrough in the 1980s when MRI became more widely available. And this is the first time that we could actually see the MS in a person's brain without like doing a biopsy or an autopsy. Anyway, the patients like this a whole lot better. On this particular setting, there are different settings on an MRI machine, and maybe one of these talks will be about MRI at some point, but on this particular setting, the spinal fluid is dark and the brain is gray and MS lesions are white. So all of these white spots are lesions for MS. So you can see more easily on this why it's called multiple sclerosis. This MRI slide is where they give you that dye, and probably almost every MS patient knows what I'm talking about with the dye. The left side of this picture has no dye, and the right side has the dye in it. This dye is normally too big to get out of the blood vessels, so it just flows around in the blood vessels, and the kidneys just filter it out and you pee it out a few hours later. But if the blood vessel is leaking, then the dye can get out of the blood vessel and get stuck in the brain. And you can see on this right-hand half, there are these white spots. And the setting on this particular setting of the MRI machine, that white is that dye. And those are areas that the blood vessels are inflamed with the immune system attacking, and it causes the blood vessels to be leaky and the dye to leak into the brain. After a few hours, it'll leak back into the blood system, and then again, you'll pee it out in a few hours. But that's what it looks like, and those areas are acute MS attacks that are actively inflamed the day that this MRI was done. So the reason we do the dye with the MRI is to see if there was an inflammation the day that the MRI was happening. MS is a very frustrating disease for patients and doctors, and one of the frustrations is that it's really hard to predict the disease. There are different patterns that the disease has, and it might be helpful to realize where these patterns came from. it turns out that in the 1980s, we were using a lot of different language to describe the clinical course that patients with MS would have. And it was particularly difficult between North America and Europe, because not only do we actually speak different languages, but we were using the English terms differently. So a survey was sent out to neurologists. There was 215 MS experts around the world that received them. I was one of the unfortunate ones to get it. And I say that because it was just torture. It was an essay question, and it was half a page per question, and it had something like 30 questions, and it just said, what do you think relapsing remitting MS is? And what do you think, benign MS? And at the end of when they collected the results, it turns out that most of the terms, it was just all over the map. There was no consensus about what people meant by these terms. But there were 4 terms that there was a fair consensus on. And so those were declared the official terms, and we decided that we're not going to be using that other language. We're just going to talk in those 4 terms. This was key, actually, because they had done power calculations of how many patients are you going to have to put into a study to find out if a drug works, if we had a drug. Back then, there was no drugs even on the drawing board, but people were thinking, like, if we ever could get one, like, how many? And the answer was 2,500 patients, which is an impractical number. By choosing patients that only had relapsing remitting disease for these initial studies, those studies were done with around 250 to 450 patients. So by narrowing the type of person that we enrolled in a study, we decreased the statistical noise, and were able to do a study with much fewer patients and prove that our first drugs worked. And the first drug came out in 1993. Anyway, this has gone through a couple of modifications now, and there are 3 major patterns that MS follows. And the first is relapsing remitting. With this, the way it works, patients are minding their own business, and then they'll just come up and have an attack where something will go wrong. The symptoms that happen depends on where in the brain the lesion lands. So if it lands in your eye, you'll have trouble seeing. It will come on over a few days. It usually maxes out at maybe 7 to 10 days. And if you do nothing, it will slowly improve over several months. The problem is it may not improve completely 100%. So if you look at that upper part of this slide, that first panel in the middle under relapsing remitting, that person got completely back 100% to their baseline. But on the right-hand panel of relapsing remitting, that person did not regain back to 100%. So over time and a series of attacks, they lost ground. Another type is primary progressive MS, where they don't really have attacks so much, but they just slowly lose ground over years. The middle panel there shows that person just had a slowly predictable down or uphill course in this one. And then on the right, on that same primary progressive section, that shows that some people, they can speed up or slow down and maybe even get a little improvement at times. But they generally don't have attacks and just slowly lose ground in the absence of attacks. The other one is on the bottom with secondary progressive MS, and that's kind of a blend of the other two. They start out with relapses, just like relapsing MS, and usually after 10 or 15 years, they start having the baseline slide slowly, just like the primary progressive MS. In the first panel of that, they may have a purely progressive course after it starts that way, but more commonly it's like the bottom right-hand one, where they will still have a few attacks scattered across, but their baseline is not stable between attacks. People, when they come into the clinic, seem to spend a lot of brain power trying to figure out what kind of MS they have. And I just want to say that I'm not nearly as concerned about that as the patients are oftentimes, because I think the reason patients are so interested is they think that this tells them something about their prognosis, and it really does not. Despite the fact that it has scary terms in there like progressive or unscary terms like remitting, the prognosis is the same if you start the clock at the same time. So if you start with someone who's having trouble walking and you ask how long does it take them to go from walking to walking with a cane, it's the same amount of time for all of these types of MS. So I think, as a patient, you probably could use your energy for some other aspect of the disease instead of worrying about this so much, and worrying more about what treatments you might want and things like that. A little bit about the nervous system. So the nervous system is divided into two big parts: central nervous system and peripheral nervous system. The central nervous system is the brain, the spinal cord, and the optic nerves going to the eye. So MS only affects those parts of the nervous system. It does not affect peripheral nervous system going out to your limbs, and it does not affect or it doesn't attack other organs. Any involvement for other organs is because the nerves go into those organs might be affected, but generally it's a pure central nervous system disease. Our nervous system consists really of a bunch of wires, and these wires take information from one place to another place within the nervous system. Some of these are really short, just taking information to the nerve next door, but some of them can be quite long. For example, they can go from the top of your head all the way down to the end of the spinal cord, which is about where your belt is. So they could be 2.5, 3 feet long. These long processes that the cells have that go this long distance are called axons, and they're about 1/10 the diameter of a human hair, which is pretty amazing when you think that in your neck you can sit there and crick your neck around for a lifetime and not break that wire that's 1/10 the size of a hair. If you had a copper wire and you did that to it, it wouldn't last very long. Many of our nerves have myelin on them, and this slide shows that there's a cell called an oligodendrocyte which makes the myelin, and it sends all these little projections out to its neighboring nerves, and these projections are really a sheet like this that wraps around the myelin, several wraps around it, and makes this sausage-shaped thing that's a segment of myelin. As I mentioned earlier, this has a lot of fat in it, and fat is an excellent electrical insulator, and it insulates this wire sort of like the insulation on a regular electrical wire. With MS, it's that myelin that bears the brunt of the attack. This shows you sort of how this works, and at the top, this white bar is a pretend axon, and you can see that red electrical signal going down the axon. The axon will conduct electricity without myelin, and some of your nerves are designed to do this without myelin, but it travels at about 11 miles an hour. Which is not very fast. Certainly not fast enough for you to escape being attacked by a saber-toothed cat if you were a caveman, or, or to avoid a bus in downtown Seattle. The middle one shows what happens if you put myelin segments on the axon. And because those segments are insulated electrically, it forces the electrical signal to jump from the gap between myelin, from one gap to the next gap to the next. And with that, if you're talking about a large nerve, the speed may speed up to about 270 miles an hour, which is a third the speed of sound. So that's a whole lot better when you're trying to avoid a bus. MS, down at the bottom, that myelin is attacked and stripped off the axon. So the signal, electrical signal, can go until it runs out of myelin, and then it will either suddenly slow way down because it doesn't have myelin to speed it up anymore, or it will fail to cross that gap altogether. So the main problem with MS is that these electrical signals are failing to get where they belong to in these areas where MS has attacked the nervous system. Most of our circuits for sensory and motor functions have two nerves in the circuit. And one of them starts at the brain and goes down the spinal cord. So you can see that with this red dot that's moving down. And then when it gets wherever it's going in the spinal cord, it jumps to the second nerve, which is in the peripheral nervous system, and it takes it from the spinal cord out to the muscle or wherever it's going. As I mentioned earlier, if you're talking about a signal that's going down to your legs that has to go pretty near the entire distance of the spinal cord, that nerve could be 2.5 or 3 feet long. And the longer that pathway, the greater the chance it's going to get hit somewhere along that path, and the signal would fail to get through. This lower one, the blue one, not affected by MS because the peripheral nervous system is not affected by MS because the myelin there is slightly different than the myelin in the central nervous system, so it's spared. The next several slides will talk about some of the common symptoms of MS that result from failure of those signals to get through. But most of these involve white matter of the brain and spinal cord, and most of them involve signals that are carried over a long distance across the body. And that's because the longer the distance, the greater the chance that a random spot's going to hit somewhere along that. I'll just go over some of them. So motor symptoms, if the signal fails to get down the spinal cord, then that second nerve going out to the muscles is not able to get its signal, and you get weakness because the signal to move your limbs just doesn't get there. When that happens, oftentimes the spinal cord, which is not getting the signal, just makes up its own signal. And spinal cords are not so smart. So they often come up with a signal that's not very helpful. And we call it spasticity. Spasticity is not only weakness, but the muscles are told to be stiff by the spinal cord. So people with that, the limbs that are affected by it would be stiff. That's also what makes people's reflexes brisk. So when the doctor is checking your reflexes with a reflex hammer, spastic limbs jump too much. A lot of patients in our clinic will say, oh, well, at least I've always had really great reflexes. And I'm like, oh, that's not good. The other thing that happens is, for those who have gone through this, that test that the doctor scratches the bottom of your foot called the Babinski test, that is a symptom or a sign of spasticity as well. And then the final thing is that people get spastic leg jumps where their leg will just jump on its own like that. Some of the other motor pathways, ataxia is a type of lack of coordination, and so it can affect coordination. And then some people can get a tremor from the MS as well. Vision, the optic nerve is part of the central nervous system, so you can fail. Yes?
Could you explain ataxia a little more?
Ataxia, the question was, can I explain ataxia? And it's the signals to the muscles are not coordinated properly. It literally means that ataxia, the lack of measurement. So you miss your target. So if I'm trying to touch this, I'm just all over the place trying to hit that target. With the vision, if that optic nerve is affected, then the signal, the light signal coming into the eye never reaches the brain, and you'll be blind in that eye. Most cases of MS that have this don't go flat out blind, but they might drop to maybe 20/50 or so. In addition, you have nerve controls for lining your eyes up together, and those have to be exquisite, and those can be affected. And if those are messed up, you can have double vision, or your eyes can have trouble holding on targets, so they bounce around. That's called nystagmus. And there's one particular finding called an internuclear ophthalmoplegia, which we call an INO for obvious reasons, because I don't want to say that twice. And that's a very specific way that the eye movements are messed up. It's when we see that, we really think about MS because it's the most prominent disease that causes that. The INO is a common reason that patients go to the eye doctor with complaints that they can't read. And the eye doctor, we've all been there, they cover one eye and one eye at a time, check your vision, and they say, oh, they're 20/20, I don't know what you're talking about. Well, what you're talking about is that your two eyes are not tracking together, and when you're reading, they need to track perfectly to see the text. So if the two are like not going the same way, then you have trouble reading even though you have 20/20 vision in both eyes. So it often helps to have a vision evaluation by a doctor that knows this field some. Sensory signals are also very long. They're not going from the brain down the body, they're going from the body back up to the brain. So again, if you have a sensory signal from your leg, it would go in that peripheral nerve up to your spinal cord, and then up the spinal cord and the first nerve back up to the brain. So again, 2.5, 3 feet long for some of these. If the signal fails to get to the brain, then you get numbness, because the brain's getting no signal. It says numb. So that can happen, but also the signal could get to the brain but be jumbled up when it gets there. And the brain then tries to come up with what is this? And it often gets it wrong, of course, with a messed up signal. And what we often get is called paresthesias, which just means that the sensory signal is not coming through correct. We've all had paresthesias. When your arm goes to sleep because you were lying on it, you're not cutting off the circulation. You're actually lying on the nerve out here in your arm. And then the signal, as it comes from your arm up to your brain, is getting messed up and jumbled. And your brain gets this signal and says it's pins and needles. Fortunately, with your arm, when it does that, after 15 minutes or so, it'll get its act together and start working again, and the pins and needles go away. Same thing, you go to the dentist, they give you medicine to numb that nerve, and as it's waking up, it's getting a few signals through, but they're jumbled, and you get pins and needles, and it makes it feel like your face is this big, and those are all paresthesias. So you can get that with MS, and they can be really odd a lot of times. Every time I think I've heard it all, then someone comes up with another one that's a description, but bugs crawling on them, liquid running down their limb, of course the pins and needles, burning, things like that, vibration things, all sorts of things. Pain can also be one of these signals. Probably about a third to 40% of MS patients have pain. A lot of those are because, not because directly the MS, but just because they get joint pain. If you're limping enough, you'll get back pain from limping. But some of it directly is the MS with messed up nerve signals. One of the types of pain that a person can get is called trigeminal neuralgia, which is facial pain because the nerve that does the face can be affected. And some of the studies would indicate that perhaps 7% of MS patients might have trigeminal neuralgia. It's really important to recognize that because I've seen people that go to their dentist and they come out with like all the teeth pulled on one side, and it's not dental. It's it's this trigeminal neuralgia paresthesia. The other one is this Lhermitte's phenomenon. And Lhermitte was French, so that's why his name is pronounced like that. He described that if you bend your head down, that you get this electric buzz in your neck and it goes zipping down your spine, maybe into your arms or legs, and then it's gone. And you wonder, like, man, what was that about? And that is another one of these paresthesias from MS. There's some paroxysmal symptoms, which means they come kind of in like waves, and you can get pain or paresthesias with that. You can also get like spasms from it. Trigeminal neuralgia usually comes in waves. And then this Lhermitte's phenomenon occurs, of course, when you bend your neck. The autonomic symptoms, that's bowel, bladder, and sexual dysfunction, those are actually the longest nerves in your nervous system, and therefore they're quite common with MS. With bladders, you can get urgency where you gotta go and you gotta go right now. Or you can have hesitancy where you think you need to go, but then you go and like nothing happens and you have to wait and wait. Or you have the unfortunate patients that have both, where they got to go right now, they run in there and then nothing happens. Drives them crazy. Bowels, constipation is really common with MS, 85% or so of people. And then urgency, you can get fecal urgency as well. And then sexual dysfunction, both men and women can have a lot of sexual dysfunction for a number of reasons, but those nerves have to be really carefully coordinated to get proper responses, so it's a common area that doesn't work right. There are a few symptoms of MS that kind of break the pattern of information being carried over a long distance, and one of these is fatigue. It is actually the most common symptom of MS in the upper 80% range, and is just a feeling of exhaustion. They tell me like getting out of bed exhausted me. We don't entirely know what causes the fatigue, but the theories, there are two kind of prominent theories about it. One is that the immune system is just activated and that causes fatigue. And one way to think about that is like the last time you had the flu, remember how tired you felt? Well, when your immune system is activated, it really makes you feel wiped out. The other thing is that fatigue may be due to just requiring more brain power to do your normal functions. We did a study many years ago where we took MS patients, and there's an MRI technique, functional MRI, where you can have the patient do something and you can measure what part of the brain is active in doing that. So we made them tap their finger And the other side of their brain that controls that finger, there'll be a little area that the brain is driving their finger to tap, and it'll light up on the scan. With that study, we picked patients very early in disease, so they were pretty normal, really. And their finger tapping speed was normal. The area of the brain involved was normal. But then we gave them a task that was a bit harder, a cognitive task, and we gave them a yes and a no button, so they had to say true or false. And we gave them kind of math questions, like 4 is less than 9, true or false. And then we would mix it up a little bit with a double negative, true or false, 4 is not less than 9. And these patients scored normal on this test, but the area of the brain that lit up to answer that question was 4 times larger than a normal person. So they were functioning normal, but it was taking 4 times as much brain activity to be normal. And that probably is the bigger contributor to fatigue, because just constantly working that hard to function is exhausting on your system. Another one is heat sensitivity, and this is straight physics. If you take an electric wire, and if I had a Bic lighter and just heat up the wire, the hotter the wire, the resistance increases, and you could eventually get the wire so hot that you can't get any electricity through it. Your nervous system is the same way. So if you get overheated, it's harder to get electricity through. And with an MS patient, if they have an area of weakness, like from a lesion in their nervous system, the signal may fail altogether, and they may get more symptoms when they're overheated. When they cool off, then they go back to normal. But when they get overheated, they may have more symptoms. Not everybody has this, but about a third or so of MS patients are heat sensitive. Back in the day, this was how we diagnosed MS, with a hot bath test. And I believe I performed the last attempted hot bath test in Seattle. And we had a poor patient that we thought had MS. And so we took him up to physical therapy, put him in this tank called a Hubbard tank. It's kind of like a whirlpool. And you do a neurology exam on them, and then you put them in the water and turn the heat on and raise their body temperature by 1 degree. So instead of 98.6, they're 99.6. And then you examine them again, and if they had more findings, they had MS. So we put this unfortunate person in there, and in maybe, 10, 15 minutes into it, there was this explosion in the room next door, and we literally blew up the boiler. And we had all these maintenance people crawling around, and they said, oh, it'll be fixed any minute now, any minute. And 3 hours later, it was still not fixed. So we hauled the guy out of the water. He was shriveled up to a near prune by that point. And then 2 days later, he got one of the first MRIs in the city in a trailer that was parked out front of the hospital. And I remember thinking, whoa, that MRI is way easier than doing this hot bath testing. Restless leg. Some studies indicate that maybe up to a quarter of people have restless leg, which is a weird, it's a weird symptom in the legs, and people often have a hard time describing it, but it's just uncomfortable, and if they get up and walk, it goes right away, which is why it's called restless leg, because when they try to sleep, this happens, and they have to get up and walk to make it go away. And then cognitive impairment is seen in about 60% of MS patients. It's not, it's subtle. In Alzheimer's disease, the information that you're storing in your head is stored by the nerve itself. And with Alzheimer's disease, that nerve dies. So if the nerve that was holding your birthday dies, you just lost your birthday. With MS, the nerves are mostly intact. What's missing is the myelin to get the information from one place to another. So they still know what their birthday is. It just takes them a long time to dredge it up. What this means is that most patients have, they have knowledge in their head, but they have trouble thinking rapidly or moving this information around inside their head, and it usually translates to difficulty with multitasking in modern life. People also have memory, trouble with short-term memory, and they can get any of a number of cognitive aspects or cognitive problems, depending on where the lesions are landing. But for the most part, it's important to recognize that the tests that pick this up are processing speed tests. And if you do the knowledge-based test for Alzheimer's disease, you will miss the cognitive impairment on this. This is particularly important when people, if they are going for disability, because if you go to a psychologist that does mostly Alzheimer's, they'll do the wrong test and miss your deficits. Now a segment on what causes MS, and I could just shorten this and just say we don't know, and then we go home early, but got to keep talking. We know the immune system is up to no good in this disease, and there are many components to the immune system, and I'm not going to go in great detail about it because that'd be a good topic for MS 201 or something. Of these components of different cells in your blood, it's this lymphocyte group that seems to be the biggest problem in MS. And it turns out that there's not just one type of lymphocyte, there are many types of lymphocytes, which is a type of white blood cell. So there are B cells and T cells, and then the T cells are subdivided into CD4 and CD8, and then it divides and divides, and there are many, many different types of cells involved. So if you ever try to read about what causes MS, you'll quickly get lost in this huge discussion of CD this and CD that, but just know that they're all different types of lymphocytes. They do different things on attacking a target, and pretty much all of them seem to be inappropriately activated in MS. The immune system is targeted against the myelin for reasons we don't understand, but pretty much every component of it has a way to attack this myelin and strip it off of the axons. So we know the immune system is messed up, but we don't know why. But there are hints about things that could be going wrong. So one is genetics, and a lot of people ask me, is it a genetic disease? And the answer is no. About 20% of people that have MS will have someone else in the family that has MS, but you have to go out to cousins, aunts, uncles, kind of out that far to find someone else in the family oftentimes. The risk of a sibling or a parent or a child with MS is about 4% for women and 1% for men. So if a person has MS, the risk of a mother, a sister, or a daughter is 4%, and then the male counterparts of that is 1%. So it's not really like a genetic disease, which would be 25% or 50% of the relatives were getting it. It's higher than the general population, but it's not inherited like your normal inherited diseases. Identical twins, which is monozygotic, is what that means. If one twin has it, 25 or 26% chance the other twin will get it. There's these genome-wide association studies, or GWAS studies, and with this they look at hundreds or thousands of genes, and the most recent study that I'm aware of looked at 500,000 genes for MS. and look, is it more common in MS patients than normal patients? And to date, there are over 200 genes that have been identified that are more common in MS patients than normal people. But if you roll all 200 of these together, it still explains less than 10% of the risk of this disease. So there's some genetic propensity to get the disease, but it is not inherited it doesn't have a really strong genetic background. Geography things I think are really interesting, and there are several geographic hints. One is that it's more common in the north, and I'll show you a slide or two about that. But also, they've done migration studies of people moving between like northern areas of the world to southern areas and vice versa. And the risk of getting MS is determined before the age of 15. However, people usually don't get it, MS, until 20 to 50. So what is happening before the age of 15 that is setting people's risk a couple of decades later? There's also clusters of like mini epidemics, if you would, of MS, and I'll show you one of those. They've looked at almost everything that you could imagine to try to explain the geography, and really they don't understand it yet. This was a study that they looked at veterans, because veterans have about equal access to health care. And they looked at people, the upper one is Vietnam era veterans, and then the lower one's World War II veterans. And you can see that MS is more common in the north than the south of the US. But there's been some filling in of the south. Like Arizona has gone up, for example, and Nevada and Utah are going up even in that short time frame. This one's a little hard to see, but this is looking at the ratio of north to south. And if you just look at white men, World War II veterans had about a 2.5 times, if you lived in the north, you were 2.5 times higher risk of getting MS than if you lived in the south. But by Vietnam, it was down to about 2. So it's interesting that there's this north-south gradient, but it's even more interesting that it's changing. And what we think is going on is it's holding steady in the north, but it's increasing in the south for reasons we don't understand. It's increasing not only in the southern US, but the southern part of the world in general. And this slide is a world survey done in 1994 on the bottom, and in 2003, so 9 years later at the top. You can see like southern US is filled in. There's places like Brazil that were extremely rare before, now are moderate risk. Areas around the Mediterranean are filled in. So it is spreading not only southern US, but to more equatorial areas of the world in general. This is the capital of the Faroe Islands, and is the most famous like mini epidemic. The Faroe Islands are halfway between Scotland and Iceland, which you see in this map down on the lower right. And there were no cases of MS on the Faroe Islands until World War II, when the British invaded. And the British preemptively took these islands to control German shipping lanes coming out of the Baltic. And this is a map of the island, and the little hatch areas are areas that the British were garrisoned during the Second World War, and the dots are who got MS. There were 24 cases of MS within the first few years of the British arrival. And 21 of the 24 lived where the British were garrisoned. The other 3 did not, but they worked basically as longshoremen for the Brits. So they didn't live there, but they just worked for them. So some people think that this was an epidemic brought by the British, and this shows the number of cases starting in 1940. So there's this big spike of cases, and then a second, a third, and a fourth blip. And this models with what happens when you take a naive population that has never seen a virus and expose them to a virus that they're not immune to. So some people think maybe the British brought a virus that was somehow causing MS, but others argue that they brought something far more dangerous than a virus, which was the first neurologist. And that this was simply, a diagnosis. They never had a neurologist. Nobody got diagnosed before. But, as a neurologist, I just have to say that I can't believe that a family practice doctor would miss every single case of MS. Surely they would realize that somebody had a major problem and try to figure out what it was. There's the issue of sex. So about 3/4 of MS patients are women. But 100 years ago, it was 3/4 men. And people don't like to talk about that because it's hard to explain. The women surpassed men in about 1960, and it is continuing to get more and more female every year. So this particular study shows the ratio of men to women, or women to men. And you can see that it's going up at about 0.85% more female every year. This study ended in 1980, but there are some other studies that have shown similar things continuing into the current time. And it is really hard to explain. How could there be a shift from mostly men to mostly women? And one explanation is that doctors back in the day, being mostly men, were just biased against women, and if a woman came in with some of these weird symptoms I was talking about, they would just be labeled hysterical, whereas a man comes in, oh, it must be something serious here. But it is hard to actually conceive that they would shift from 3/4 men to 3/4 women based entirely on just blowing off the women's symptoms as hysteria. So I think most people think that it's truly increasing in women, and especially these modern studies where we're hopefully more enlightened about how to approach diagnoses. Racial things. So traditionally, whites get it more than blacks, and blacks get it more than Asians, and Native Americans are about the same as Asians. It's really hard to study racial groups because there are inequities in healthcare that just make it really hard to get good numbers. But this particular study was done in veterans, which at least financially they have equal access to healthcare. Because the VA or Department of Defense will pay for their MRI scan if they need it. So if you look at this first column of numbers, this was World War II and Korean veterans, and they set the risk of a white male at 1. So if the risk of a white male getting MS is 1, black males had 44%, the rate that white males had. And then down at the bottom, you can see the white females, it was about 1.8, and black females was about 1.3. You move to Vietnam, and these numbers start shifting. So if a white male is 1, a black male is 2/3. So it's gone from 44% to 2/3 the risk of a white male. And if you go over to the far right, this is Gulf veterans, and it turns out that black males have slightly surpassed whites. And the same numbers are similar for women. So again, it is really hard to explain this, that how we could have such a massive shift in the risk of MS based on racial changes, just like the changes in women and the changes in geography. There's a similar study in the Kaiser system in California that showed pretty much identical findings as this one. People have been looking a lot to try to figure out what is causing this, and the answer is we don't know. But they've looked at viruses, and some viruses increase your risk of MS, such as EB virus, which is the one that causes mono. But some viruses decrease your risk of MS. So if you get another virus called CMV, your risk of MS is lessened. Vitamin D, of course, is low in people that live in the north. Does that cause MS? And is it more common in the north because people get less sun and less vitamin D? There's no question that MS patients have low vitamin Ds, but there is a huge question as to whether replacing that vitamin D makes any difference. There are several studies, at least 3 large studies that are underway right now, where people are randomly assigned to high-dose vitamin D or low-dose vitamin D, or sometimes vitamin D versus placebo, to try to answer the question, is vitamin D playing a role here? Smoking, I guess, as a doctor, you assume that I'm going to say smoking is bad, so it's bad. But it's bad not only for all the other diseases, but it increases your risk of getting MS. And if you already have MS, it increases the severity of the MS. So stopping smoking is a good thing. There are a couple of reports that high salt intake may increase the risk of MS. And then there's some reports that say it makes no difference. So the jury is still out on salt. And then there is just really the first paper just came out like a month ago, saying that that employment exposures to organic solvents like painters and people that work in the chemical industry have an increased risk of MS. But that's really the first report, and we will probably need more studies to make sure that that wasn't just a fluke. So this slide is, I realize, not very good, but it's the best one I could find, about this woman, Lidvina, who was born in 1380. And when she was about 15 years old, she is Lidvina van Schiedam. Schiedam is a suburb of Rotterdam in the Netherlands. And when she was about 15 years old, she was big into ice skating. And she had this attack of some disease where she just suddenly lost all of her coordination. And nobody knew what this was back then, but she prayed really hard and got better. So it was a miracle. And then she went on to have multiple additional attacks, and she eventually became disabled from this, but she devoted her life to good deeds and lived to be 53 years old, which was not too bad back then. And that was kind of it. But anyway, the Belgians invaded the Netherlands, and the people many years later, and the Netherlands people were not pleased about this. So the Belgians thought, how can we pacify them? And they thought, we'll give them a saint. So they went and they found this Saint Lidvina person, and they actually made her a saint. She's the patron saint of ice skaters. And this used to be a Catholic hospital, and they had nuns and priests walking around here all the time, and everyone that I could find, I would ask, hey, what can you tell me about Saint Lidvina? None of them had heard of her. But I can tell you that in the Netherlands, she's big. They all know who Saint Lidvina is over there. But she was historically probably the first patient to have MS. And I think this is really important to keep in mind, because when you think of industrialization and nuclear fallout and horrid diets and stuff, the first case came from farm country back then in a very rural setting in the Netherlands, where they didn't have, and this way predated the Industrial Revolution. So it is likely that this disease is not caused by chemical contaminants and all this kind of stuff that we worry about in modern age, but it is probably caused by something that goes back at least 600 years.
It speaks to lack of sunshine.
She was north. These are the treatments. I spent a lot of time, a couple months, trying to collect this one slide together. But this is the treatments for multiple sclerosis from St. Lidvina, who came down with MS in 1395, all the way to 1870 when Charcot, who's that French guy that described MS for the first time, he did the first attempt to treat it. And these are all what we view as pretty wacky treatments over that time. So divine intervention is what Lidvina used, and I used to say I think that probably it's still the #1 treatment that people pray to get better, but it turns out that's not true. More people use vitamins, over-the-counter vitamins and supplements, than pray to get better nowadays, which, social commentary there. Anyway, pretty wacky things on this list. Electrical treatments, which is basically electrical shocks, or strychnine, mercury, Spanish fly, which is an irritant that makes you just itch like crazy, arsenic, this shaving the head. I didn't have room. They actually shaved all your hair off and they put iodine, which is kind of like that orange soap that they use like for surgery, on your head. Anyway, we now look at this and think, this is nuts. But all of these treatments made some sense at the time, and we would still be shaving your head and putting iodine on it, except we've done scientific studies to see if these treatments actually work. So nowadays, there are 14 drugs on the market, and I'm not going to go into great detail with these because that's MS 201. But these have all been studied with actual scientific studies to show what their risks are and what their benefits are. I have several slides here that I'm also not going to go into detail, but I just want to kind of like shock you with a list of several slides of things that are currently in studies to show that people are actually trying to find answers for this. So here's one slide. I just missed the button. Here's another slide. Here's another slide. And then there's another slide of symptom management to try to help the symptoms rather than slow the disease down. And then there's also studies, so there are about 75 drugs in human studies right now. We at our center have 33 studies going right now. So it's one of the most active areas of neurology research. This slide shows 4 different lines of research of trying to figure out how to repair the myelin damage that's been done. And there's a few that have just come up in the last few months that I haven't added to this list yet. There's also stem cell studies going on in MS. And the NIH has just funded a phase 3 study that we just got the protocol and are working on the contracting, and we just got that like a week ago. So a huge amount of research going on in this area, and even though we have 14 treatments now, it's one of the most rapidly advancing areas of medicine today, and we're going to have way more and hopefully better treatments in the future. So this is my last slide, and I hope I've given you some insight into what causes the disease, and hopefully broadened your view of what the disease is like. So thanks for coming out, and I'll hang around a little bit if there are more questions. So, yeah, thanks.